morning, everyone. At the outset, I would like to thank Dr. G V sir for having given this opportunity, and I would like to thank the scientific committee also. Good morning, chairpersons. So, very well dealt. Dr. Ranjit did a very good job of almost explaining, taking many of my topic also, and my job has become a bit easier. So hypoglycemia, as he rightly pointed out, it's a very, very common problem that we encounter in our ERs. And many a times, patients don't come out with the history of hypoglycemia. And usually it's being diagnosed as a low plasma concentration that exposes subject to potential harm with proposed threshold plasma glucose of less than 70 milligrams. And it's an important complication of glucose lowering therapy. It's more iatrogenic. We are causing more harm to our patients, in fact, if we don't treat them well. And of course, we have been always concentrating on intensive glycemic control. And of course, we are concentrating on the numbers. We go behind the numbers. But instead of going behind the numbers, we have to go behind the exact symptoms and so on. So we have to, as rightly pointed out, the history taking is so important. And many times we misdiagnose of hypoglycemia, as well as the problem is there is a very high chance of death in case you don't properly take care of it. The myth always happens, like type 1 hypoglycemia is severe more and type 2 doesn't happen. It is not so. Then a study in Scotland, they just a DART study, they proved that almost severe hypoglycemia occurs equally, above 7% in both studies, both in type 1 and type 2 diabetes. So this has to be borne in mind when we are treating with type 2 diabetes. And many people think that when you don't give insulin, the hypoglycemia is less. When you give insulin, hypoglycemia is more. For GPs, you should all realize it's all the same. Whether glucose lowering therapy will definitely cause hypoglycemia. So after DCCT and Wikipedia trial, all of us are convinced that strict glycemic control definitely improves HbA1c reduction by 1%. It definitely improves the complications of micro and macrovascular one. So we are reducing to the extent of 30 to 35% of microvascular and macrovascular complications. But so it's been clearly told that we have to maintain the HbA1c below 7%. And many of the studies after that, ACCORD, ADVANCE and VAT trials, all those studies have clearly shown that intensive glucose control arm definitely exposed to more hypoglycemic episodes. So that has to be borne in mind. And there's threefold increase of risk of hypoglycemia are encountered in all these trials. And the Stockholm Diabetes Intervention study very clearly pointed out against more of hypoglycemia. So all the studies which have been pointed out, DCCT and EDIT trial, follow-up trial, Wikipedia, ACCORD, ADVANCE, all these things you can have seen hypoglycemias, they have encountered hypoglycemia in all these areas. But definitely the definite CV benefits were there in the first three studies. So that goes to show that even though we are concentrating on HbA1c reduction of more than less than 7, we have to be very careful about hypoglycemias. So that has to be borne in mind. Of course, the mild, moderate, and severe can divide into three. And when the blood sugar falls below 40, it's severe, and of course moderate is 55. And of course, 70 to 55 is mild. So many often patients don't come out with a complaint. So what are the causes of hypoglycemia? In fact, Dr. Ranjit has discussed in detail about that. And so it's incorrect insulin administration, that is so important. The insulin taken in excess at the wrong time. See, we have seen several stories of this. Patient getting insulin injection and waiting for the diet. And suddenly there's a problem at the next door. So he went and helped a patient. Actually, there was a patient, and that patient was sent to my hospital in ER when we received. And followed by this patient arrived actually with hypoglycemia. That the previous patient, the neighbor was having a medical problem. The person who took insulin did not take food. He went and helped him, and this fellow actually fell with hypoglycemia, and he was brought again into ER. So these kind of inadvertent insulin administration, and again not taking diet properly, and of course insufficient exogenous carbohydrates, again not taking enough diet, and many times in old age when the people are having concomitant illness, they don't take proper food and they just miss diet, or they don't take correct calories. It can happen. So insufficient exogenous carbohydrate, and then decreased endogenous glucose production due to excess alcohol consumptions definitely do happen here. And liver cell failures, you can have the glucose production so low, that can also go. and liver cell failure, and an increased utilization of carbohydrate and depletion of hepatic glycogen stores, as happened in exercise. When you do, especially in type 1 diabetic patients, when they go for exercise in the evenings or when they play, suddenly they are supposed to encounter the hypoglycemia. In that case, you have to take a small snack before going for exercise. That advice need to be given. And sudden weight loss also is one of the reasons for that. And of course, increased insulin sensitivity, especially during the nighttime exercise and weight loss, and delayed gastric emptying, as is very, very common in a diabetic gastropathy and an advanced stages of stage 2 diabetes, where autonomic failure is there and gastroparesis is there, that can happen. And decreased insulin clearance, as it happens in renal failures and CKDs. And actually, many a times, a patient who had got 350, 380 milligrams for the past almost 6 months to 1 year, you would have increased the dosage. Suddenly, the patient comes to the ER with emergency room with a 50 and 60. Most often, the diagnosis is reduced EGFR. You can see just creatinine 1.4, 1.5. Previously, would have been 1.1. Due to some problems, the creatinine would have gone up. And that 1.5, if you just calculate the EGFR, it would have been definitely less than 30, 40 when compared to the normal, when compared to the previous value. So these are the common things that we see, and progressive renal failure is one of the very important causes of hypoglycemia in this. So normally what happens when the sugar goes down, there is increased endogenous glucose production. So whenever you are starving, you are not taking diet, the indigenous production of glycogenolysis and gluconeogenesis definitely increase the glucose. This is one of the compensatory mechanisms that happens physiologically. So there is also behavioral change that happens when just we start overeating, so we compensate. So these two things happen normally, that's a physiology. Whereas in non-diabetic patients, the response is very good. So while glucose concentration, when it's still low level, it's not a problem in the normal patient. But additional drop in glucose will cause increased secretion of glucagon and epinephrine. And these hormones, along with the sympathomimetic hormones, they actually improve the relative consumption of food, and patient definitely become better. But in a diabetic patient, it's a reverse. It's not happening properly. There is intense adrenaline leading to appearance of relevant symptoms like adrenaline symptoms of hypoglycemia, which was nicely pointed by Dr. Ranjit. And of course, additional lowering causes the cognitive symptoms, even convulsions and loss of consciousness can happen, especially in a diabetic patient. In normal patients, in normal physiology, it doesn't happen so often. The defense mechanism are often impaired in patients with diabetes. That's a problem. So it is not normal. So because it's pathologically, it's often impaired, and significant beta cell failure will lack in insulin response to a drop in insulin. This leads to delay in secretion of glucose from the liver during the hypoglycemia. That is also a reason why sometimes you get hypoglycemic unawareness and people get into more problem. So this is a common issue that we all face in diabetic patients. So in advanced diseases, it is so important that sympathetic adrenal system also get blocked. And when that gets blocked, you don't get the usual adrenergic symptoms that people get a warning. And that is also one of the reasons why patients go for a hypoglycemic unawareness. Of course, in patients type 2 diabetes, a combined reduction in glucagon, that also happens. In type 1, it's not just insulin reduction, it's also pancreatic failure. So glucagon also is not secreted enough. In that case, hypoglycemia risk is very severe. And also, they can happen in stage 2, but it's more common in stage 1. So coming to pathophysiology of type 1, almost similar as that of type 2. It can be inadequate calorie consumption, increased insulin sensitivity, and impaired glucose production. And so the problem is the autonomic failure which happens. It's a vicious cycle, and the deficient glucagon response, impaired sympathetic adrenal system, where hypoglycemic unawareness is happening, and again, vice versa. It's a counter-regulatory hormones defect is there. So again, this needs hypoglycemia, brain adaptation is poor, and during sleep and exercise, the problem was it's a vicious cycle, and the autonomic failure worsens the hypoglycemia. So the physiological mechanisms of hypoglycemia unawareness is this. So recurrent hypoglycemia leads on to various things like reduced sweating, and the adrenal symptoms are less, absence of palpitations, reduced production of catecholamines, so absence of tremor. All these things result in patient become very much unaware of that, and leading on to the cognitive problems, and leading on to the convulsions, even death sometimes. So a lot of cardiac problems happens, and arrhythmias are very common, and CV events do happen in CAD, significant because of the cardiac problems. And so this is a very comprehensive slide where you can see the problems that happens in hypoglycemia. It's not just glucose alone, just getting out of. Once you give a glucose to the patient recovers. We are happy about it. It's not easy, and so it actually leads on to the pro-inflammatory effects and prothrombotic effects are there. The oxidative stress happens, and there's a damage happening here. And arrhythmias are very common in hypoglycemic patients. And of course, hemodynamic changes can lead on to myocardial infarction, and it can lead on to so many problems. So, hypoglycemia is not simple, and sometimes can be fatal. And there's so many effects happen, and these two happen not in all patients, but it can happen one by one after the other, and it is so dangerous. So, sudden death during sleep due to nocturnal hypoglycemia is so essential. So you have to be very careful. Sometimes when the patient's blood sugars are so level, we have to go for 6 to 7 times testing. Then only we are able to reduce the chance of nocturnal hypoglycemia. Cardiac respiration abnormalities is a result of hypokalemia due to hyperinsulinemia, increased secretion of catecholamines. All these things result in arrhythmias and sudden death. So, and regarding the counter-regulatory response, normally several counter-regulatory responses happen normally. So there is a decrease in pancreatic beta cell insulin secretion, an increase in pancreatic alpha cell glucagon secretion, an increased sympathoadrenal response with acute plasma increase in adrenaline and norepinephrine, increased secretion of ACTH and glucocorticoids. All these things are normally it happens whenever there is hypoglycemia. So hypoglycemia sort of increase again, as you told, the inflammatory response, the C-reactive protein, interleukin, and so on. So these are the things that have been explained. And the problem is the effects of induction of abnormalities of platelet function. This is also an important one which can cause problems, and that's why it's the prothrombotic effects happen, and the patient will go for an infarction and so on. And so the clinically, the hypoglycemia can lead on to so many cardiac problems, and it can even the vision, diplopia, and sometimes when the patients with the 450 when they present to you, there is some amount of refractory error happening. When the patient sugar drops down, suddenly it drops down to 100, 120 from 450 and all, patients do experience, they come and report to us when there is some visual disturbance and so on. That's also part of the sudden decline of sugars. Even it need not be just 60 or 70. When the patient sugars brought down from very high level of 450 suddenly to 150 and so on, the patients complain about that. Of course, the brain neuroglycogen symptoms and so on, and they can lead on to chance of dementia increases, seizure activity problem is there, functional brain failure, brain injury, and prolonged cerebral ataxia. All these things are very common in hypoglycemic patients. And other regulatory responses, inflammation, endothelium. So so many problems can happen pathologically. Hypoglycemia is not simple. It has to be taken care with seriousness. And it's a pictorial depiction. And of course, the hypoglycemia during the day, your patient is very much awake. There's a possibility that sympathetic response is effective, parasympathetic counter-regulation is there. So, but ventricular premature beats, QT prolongation, cardio accelerations, all this happens. The reverse is, it is reverse. The bradycardia and atrial ectopy is common. So, sudden death is very much possible in the nighttime hypoglycemia. The hypoglycemia during the night is more severe and can cause sudden death. So, all of you will agree with me. I'm summarizing. Hypoglycemia is a very common complication of diabetes. And pathophysiology is very simple in early stages where you can treat very nicely and come out. But as the disease advances, it becomes more complex. And it's equally possible in type 1 and type 2. When you give insulin, the hypoglycemia is more. When you don't give insulin, hypoglycemia, no, it's not so. Both in OHA and insulin, you can encounter. And of course, complications due to hypoglycemia, as we have seen in the pictures, it can be very mild to fatal. And all of you should bear it in mind. Treat effectively, and do not run behind the number. Always go behind the patient history, and just always ask for whether the patient is actually having any symptoms. And many times it's missed, and clinically there are lots and lots of patients who say mild tremors, tremulousness, and so on. That's what they keep overeating. That's also the reason why patients become obese. Recurrent hypoglycemia actually leads on to obesity. That's also a problem. Keep overeating. So we have to bear it in mind and adjust the dosage of medicines accordingly. Thank you very much.